Thank you so much for inviting me, and congratulations on having your inaugural Canadian Tick-Borne Disease Conference. I know, having organized a conference in the US for 20 years with the Lyme Disease Association, it's an enormous amount of work, but it's a great way to bring people together with different viewpoints to discuss some of the key issues. So I'm going to talk to you today about neuropsychiatric Lyme disease recognition and management. I have no conflicts of interest or financial disclosures, and I will be discussing off-label use of medications. Roughly, I'll be talking about diagnosis and some clinical cases. I'm going to focus a bit on mechanisms of disease, talk about neuropsychiatric studies we've done, and a bunch about treatments towards the end. I'm going to talk faster in the beginning than at the end because I want to have enough time for the stuff at the end. And I know you know a lot about Lyme disease, so I'm not going to go through this slide on the neurologic manifestations of Lyme disease, but it's in your handouts if you want to look. You know about the diagnostic evaluation, so I'm not going to talk about that either. But you should know that spirochetes reach the central nervous system quickly after initial infection, as soon as 2 weeks, and 50% may not show central nervous system symptoms. You know, of course, that there's acute Lyme disease, and then there's people who have persistent symptoms afterwards, but they don't have functional impairments. And then there are those who have persistent symptoms and functional impairments. And the research definition for that is post-treatment Lyme disease syndrome. Post-treatment Lyme disease syndrome does not mean that they don't have persistent infection. It's just a neutral term that incorporates all the various possibilities. You know the standard story, so I'm not going to go through her case, but this was very briefly, a physician who came to see us. She had standard myalgias, irritability, fatigue, cognitive problems after a tick bite. She did not see the rash. Her clinician did give her doxy because she tested positive. She was treated with doxy and got 90% better, but then she relapsed. And the next time she relapsed, the primary care doc didn't want to treat her because she had gotten the standard acceptable course of treatment. She was a physician. She says, "This makes no sense. Let me try another course of treatment." He said no, so she found another doctor to help her. So eventually she got better after 2 relapses and stayed better with the antibiotic treatment that she had had. So what's going on? Is this persistent infection, she asks, and is another course of antibiotics needed? And are the patients right? So this really puzzled her and surprised her, but it was educational. Okay, you know that 20% of patients don't see a rash, so I'm not going to have to talk about that. There are benefits associated with antibiotic retreatment. I know the clinical guidelines, international treatment guidelines, do not recommend it, but there have been at least 2 studies supporting the benefit of repeated antibiotic treatment. That doesn't mean that everybody should get repeated antibiotic treatment, but it does mean that it may be beneficial in some patients. And in the United States, a study by the CDC reported that 40% of clinicians in the US do give additional courses of antibiotics. So it raised the question of whether Borrelia infection can persist. We know from lots of animal studies that Borrelia can persist, so I won't go through that. Now, this is a great case. This case is of the bicycle boy, published in 1988 in the Annals of the New York Academy of Sciences. And it's really what led me to start studying this disease as a psychiatrist because it was so fascinating. So here was a kid, a 12-year-old boy who had had 4 attacks of swelling of the right knee over 2 years. The diagnosis of Lyme arthritis was confirmed serologically. After the last attack, he was treated with doxycycline, so that means it took 2 years for him to get treated, and he got 100 milligrams twice a day for a month. 2 months later, the patient became withdrawn and depressed. He no longer interacted with his friends, spent most of his time alone, and would no longer do his schoolwork. He ate very little and began to exercise compulsively. His weight dropped considerably. On admission to a psychiatric hospital, because he was so badly off, they had to admit him for possible anorexia nervosa. He was grossly depressed and uncommunicative. And he was not getting better with the standard psychiatric care. So the psychiatrists got together and they discussed it, and they were struck by the fact that he did have Lyme arthritis earlier, and they wondered, could this be a neurologic manifestation of Lyme disease? So they called in the neurology consult, who did a spinal tap, and found that this young boy had serum and spinal fluid antibody titers to Borrelia that were elevated. So he was treated with intravenous penicillin for 14 days, which is what they gave in those days. And within several weeks began to eat more, gain weight, and communicate. And during the following months, his behavior returned to normal. He went back to school, and in a 2-year follow-up, he was continuing to do well. So that was such a dramatic case, and it made me wonder how many cases might we be missing of people with neuropsychiatric aspects of Lyme disease, just because there are no typical signs of Lyme disease present at the time. Could this have been a case of pediatric autoimmune disorder associated with Lyme as opposed to associated with strep? Could it have been autoimmune antibodies that were causing some of his neuropsychiatric symptoms, especially the compulsive, bicycling, and the OCD-like symptoms? Yes, that's certainly possible, but he did get better with antibiotics, so it's probably both the autoimmune component as well as the persistent infection component in that particular case. Do other tick-borne or associated vectors carry infections that have neurologic neuropsychiatric effects? Borrelia miyamotoi, as you probably know, is an emerging pathogen that can cause meningoencephalitis. In our clinic, where we had a second opinion clinic, 25% of our cases were seropositive for Borrelia miyamotoi, and nearly all had never been tested for it. So we had this clinic because a lot of patients were wondering, are my neuropsychiatric symptoms due to Lyme disease or due to something else? And so we tested them with lots of different tests, and a quarter of the patients were seropositive for Borrelia miyamotoi. That means past exposure doesn't necessarily mean active infection at the time. Bartonella species are associated with neuropsychiatric disorders, and Powassan virus rarely can be deadly and certainly has lots of neurologic features when it's seen. Okay, Bartonella DNA study was done with Dr. Brightsworth from North Carolina State University, and we sent him samples that Dr. Delaney, my colleague in neuropsychiatry at Columbia, had collected from individuals with psychosis as well as controls without psychosis. So we decided to share these samples with Dr. Brightsworth to see if we could replicate a study that he had done earlier, a smaller study showing elevated levels of Bartonella DNA in the patients with psychosis compared to the controls. And in fact, we did find a threefold higher rate of Bartonella DNA in 40 adults with psychosis versus 29 adult controls. So what does that mean? It doesn't mean that Bartonella was necessarily causing the psychosis, but it raises that question, and there could be other factors going on that might be involved. Okay. The other important thing about this study was the rates of positive Bartonella antibodies were just as high in the individuals with psychosis, as in the controls without psychosis. In fact, it was higher, 75% compared to 56%. So that was striking and just emphasized to me, at least, that I don't know what it means when someone comes in with Bartonella antibodies, because I think they're quite ubiquitous in healthy people. But PCR, we do pay attention to. So I'm getting to the mechanisms of disease components of the talk here. So what are the primary mechanisms? We know that persistent infection may exist. We know from recent studies especially that there may be remnants of the infection that are stirring up the immune system to cause persistent inflammation. We know that there's immune dysregulation. We know that the brain networks get dysregulated. And we know that there may be other factors going on, such as other co-infections or other causes that were missed. So you have to think about mechanisms when you're thinking about what treatment approach you're going to use. So I won't go into this, but there's good markers of inflammation. There's markers that have been looked at for autoimmunity and molecular mimicry. There's been excellent mouse studies done, quite a few mouse studies, as well as non-human primate studies showing that the Borrelia can persist. And there was some post-mortem studies, and here's one from a patient who I had seen. And here's the spirochete in her amygdala in the brain, She had died of neurodegenerative dementia 15 years after getting well-documented Lyme disease that got standard treatment. Now, does Lyme disease have anything to do with her neurodegenerative dementia? I have no idea. But we decided to look at her brain just to see if there was ever any evidence of Borrelia spirochetes, and we did find them. So again, that raises questions. We know that persistent Borrelia remnants can trigger inflammation. So really good work by Brandon Jutras has recently shown that this highly immunogenic antigen, the peptidoglycan, persists in the synovial fluid of the mice. And also a recent study showed that it persists in patients with Lyme arthritis. So this is triggering an ongoing inflammation and causing disease symptoms. And the question is this happening as well with some of the peripheral non-arthritic symptoms associated with persistent symptoms in patients? Autoimmune antibodies have been shown to be elevated. These are Lyme patients, and these are lupus patients, comparable to what you see with lupus. Brain blood flow is decreased. Brain metabolism is decreased. All those red areas here are decreased areas of brain metabolism in our study of Lyme encephalopathy patients. And we know that there's altered neural immune functioning because the microglia are activated in the post-treatment Lyme disease patients compared to controls. So there's objective evidence of brain involvement in these patients. Okay, so neuropsychiatry. Most importantly, most mental disorders have nothing to do with Lyme disease, but some do. When you work with a lot of patients who have Lyme disease, you can easily start to think that most people have Lyme disease because they're coming to you with this problem. But most mental disorders have nothing to do with Lyme disease. There's very good case reports reporting obsessive compulsive disorder, panic attacks, mood disorders, suicidality. Sensory hyperarousal is pretty common with the neurologic cases, with severe light and sound sensitivity. Cognitive disorders can occur pretty frequently, and less commonly, you might see manic episodes or psychosis or Tourette's disorder. And these are all very well described case reports in the literature. Here's a 55-year-old woman who presents with new onset manic psychosis. She had gone camping with her family in Sweden, I believe it was, and she developed sudden mania. She was brought to the ER. She was hospitalized in a psychiatric facility, but because she developed leg weakness, they called in neurology. And the neurologist thought, well, clearly this was neuroborreliosis, even before they did a spinal tap. The spinal tap was done initially, it was negative. Probably because it was too early to catch the antibody production, but they were so convinced it was neuroborreliosis because of the combination of the radiculoneuropathy weakness as well as the central nervous system mania that they treated her with intravenous ceftriaxone. She got dramatically better, was discharged, and they repeated the spinal tap 8 weeks later, and at that point it was positive, confirming the diagnosis. And then there was a rare case of a woman with schizophrenia-like disorder who had been hospitalized in a psychiatric facility for 8 months, not getting better. Finally, someone did a lumbar puncture, and neuroborreliosis was diagnosed. She was treated and discharged and apparently did well. So I want to highlight down below here, it says 15% of the time, the spinal fluid intrathecal antibody studies may be positive for neurologic Lyme disease, but the blood tests are negative. So if you have a strong suspicion of Lyme disease in a case with person with neuropsychiatric symptoms, I strongly recommend the spinal tap in someone who hasn't yet received antibiotics to try to confirm the diagnosis. Okay, you know that cognitive problems are commonly seen in up to 90% of the people who meet criteria for post-treatment Lyme disease syndrome. So another key message, take-home message, that both underdiagnosis and overdiagnosis can be problematic. So underdiagnosis, if a psychiatric disorder is present but a Lyme infection is not treated, then mental health interventions will be less effective or ineffective. The problem of overdiagnosis. If tick-borne diagnosis is incorrectly applied as the primary cause of a psychiatric disorder, then the patient may not get psychiatric treatment because it may be overlooked or not addressed. So both are problematic. Both can lead to severe problems such as suicide. So we need to take both of these issues seriously and be careful in the way we evaluate our patients. Now, early on, the study was done in New Jersey in a Lyme disease clinic by a postdoc, Dr. Hassett, and she was looking to learn something about the frequency of depression in patients with Lyme disease compared to non-Lyme disease, compared to healthy controls, compared to people who thought they had Lyme disease, but they didn't have good evidence for it. And what she found was that depression was 4 times more common in the people who clearly had Lyme disease in the past compared to those people who had symptoms that they thought were due to Lyme disease, but did not have good evidence for it, compared to those who recovered from Lyme disease. So this was striking because I don't think this is what they expected to find, but this is what they did find, that depression was far more common in the Lyme disease, people with a history of Lyme disease. In our clinic, about 1 in 5 report suicidal thoughts who have a history of well-documented prior Lyme disease and persistent symptoms. So that's obviously very troubling. And if you focus only on those who meet criteria for depression, 2/3 of those have accompanying suicidal ideation. So all of this got me very concerned, and I'm really worried. What's going on? Why are patients having so many suicidal thoughts? Is it that they're not getting good psychiatric care? Is it that they're not getting good care for their multi-system Lyme-related symptoms that need better treatments? So I was thinking a few years ago that I don't think the medical community is convinced that psychiatric problems are part of the profile. And I don't blame them because a lot of the studies were small sample size or they had unclear diagnostic criteria. And then patients were coming to see me in a research study or someone else, but we're both psychiatrists, and so that's bias. And then some studies didn't have good control groups. So I thought, how do we resolve these issues? And I thought the only way I could resolve this issue is by inviting a colleague who has nothing to do with Lyme disease, who has no interest in Lyme disease, but who is a mental health epidemiologist to conduct the study. So I went to talk to Michael Benrose in Denmark, and he agreed to do this study. So they did the study, I reported the study, and they had no vested interest in the results. So it was a nationwide cohort study in Denmark of the entire population over a 22-year period. And the question was, is Lyme borreliosis associated with a higher rate of mental disorders, affective disorders, suicide attempts, and suicide? There were 7 million people in the study, followed over 22 years, and 12,600 of them had a hospital-based diagnosis of Lyme disease. And so what did we find? What did they find? They found that there was a 30% increase in mental disorders in those with a history of Lyme disease, 40% increased rate of depression, affective disorders, a twofold increased rate of suicide attempts, and a 75% increased rate of suicide. So that's very troubling and should alarm all of us and alert all of us to the need to do good suicide assessments. There was also a temporal and a dose relationship, which means that the rate of mental disorders was highest in the 6 months after the hospital-based Lyme diagnosis and among those who had had more than one episode. So are these results surprising? They're not surprising. Lots of studies have demonstrated that serious infections are associated with increased rate of mental disorders and suicide. And many infections, as you know, have been associated with neuropsychiatric disorders. And you all know as well that peripheral inflammation can lead to depression. So not surprising results. But there's something the general public and general physicians need to be aware of. So in some senses, there needs to be a public health alert that people who have Lyme disease, especially those with persistent sequelae, should be monitored carefully because Lyme disease should not lead to death by suicide. Better support systems and care for our struggling patients are needed, and we need to focus on how to help the diverse group of patients with persistent symptoms. Whether it's due to confirmed Lyme disease or possible Lyme disease, these are suffering patients, and there are quite a few of them. So the clinical recommendations are to monitor your patients for the mental health sequelae. If a person has multi-system physical symptoms and isn't responding to standard mental health therapies, do another medical workup and rule out medical causes, including Lyme and other long hauler infection syndromes, and include obviously a depression screening measure and a suicide screening measure in your practice, and tell people about the suicide prevention lifeline phone number, which I believe works in Canada, 988, as well as in the USS, as well as the USA. Here's this a really simple scale, and it's powerful. Have you wished you were dead? Have you thought of killing yourself? Those are the two questions you ask the patient. If they say no, you can move on. If they say yes, then you ask these other questions. Have you been thinking about how you might do this? Have you had intention to act on these thoughts? Have you worked out the details of a suicide plan? Have you started to act on your plan? If anybody says yes to 4, 5, or 6, that person should be brought to the emergency room. Okay, so long Lyme. How do you treat people with long hauler symptoms or syndromes? And what are people looking at? What are researchers looking at? What's been done? So as you know, post-treatment Lyme syndrome and long COVID have very similar features. There's chronic fatigue, trouble concentrating, muscle pain, memory problems, sleep problems, irritability. So whatever we learn from the treatments of long COVID might be applicable to people with post-treatment Lyme. So that's the good news about long COVID, that we're going to learn a lot over the coming years of treatments that may be also beneficial for our Lyme patients. So what are the potential therapies for long hauler syndromes? It depends on the mechanism. So if you're targeting persistent infection, obviously you want to repeat some kind of antiviral or antimicrobial therapy. If you're targeting immune activation, you might want to consider something like IVIG for especially patients with autoimmune neuropathies, target-specific interferonopathies, perhaps. You might want to target the neurotransmitters, the brain circuits that have been altered. Psychedelics, for example, is something that people are looking at. You might want to target the altered microbiome. You might want to consider neuromodulation or stress reduction therapies, and psychotherapy is really important for these patients who are struggling. And cognitive and physical rehab can be important. So it really depends on what approach you want to take, what combination of approaches you want to take. Sometimes people ask me, is there any evidence that repeated antibiotics has been helpful? And I like to show them this slide because this comes from the Stony Brook study that Dr. Krupp did and published in 2003. And she showed in her study that after 1 month of IV ceftriaxone for people with well-documented prior Lyme disease that had been treated, 64% at 6 months later still had dramatic improvement in fatigue compared to those on placebo. And in our Columbia study, which did not show sustained benefit in cognition, but it did show sustained benefit in fatigue, the same amount as you saw with the Stony Brook study, roughly 65% compared to 25% on placebo. And the effect size was moderate to large, which means it's a meaningful treatment for those people who get better. They were both small studies, and other larger studies did not show benefit, and there were risks associated with the IV administration, so it led to warnings about the use of IV ceftriaxone given the risk-benefit concerns. So I'm a psychiatrist, right? And I use psychopharmacologic medications, and there are a number of medications that we use for fatigue, for central pain, for light and sound sensitivity, for mood dysregulation, depression, and attentional problems. These indeed can be helpful for patients who have persistent symptoms, but they haven't been studied at all in placebo-controlled studies, so I can't tell you which ones actually work for sure in these patients, but this is what clinicians tend to use. We did a study of Kundalini yoga just because a friend of mine is a psychiatrist. He's an expert in Kundalini yoga, and he wanted to do a group therapy study. He did it for free. And he encouraged people to come in who had persistent pain and or fatigue after antibiotic treatment for Lyme disease. And they were randomly assigned to 8 weeks of Kundalini or yoga or a wait list. And what he found was that symptom severity was decreased and cognitive complaints decreased, but pain and fatigue did not improve enough to be significant. So overall symptom burden decreased and cognition improved. So that was really interesting. And the patients, I'll have to say, who participated in that study were very happy because they got to talk to other people who also had similar problems. So there was a bonding element as well. What about disulfiram? I know in a previous talk you heard a lot about disulfiram, so I'm not going to belabor this, except to say we did a very small pilot study of disulfiram. It was an open label study. We gave disulfiram for either 4 weeks or 8 weeks, and patients didn't know whether they were getting 4 weeks or 8 weeks. And we followed people up to week 14. And what we learned was that disulfiram, we know from the literature that disulfiram has significant risks, but we also saw some of those risks in our small study, and it was not well tolerated in our small study. So one serious adverse event occurred after 3 weeks of disulfiram. The person had severe abdominal pain, was hospitalized, and it turned out to be reversible, and she got better after 3 days, but she was worked up, and people were worried about what was going on abdominally in this patient. Um, Elevated LFTs occurred in 3 of our 9 patients, including one person who was only on 250 milligrams a day. So that's concerning because liver failure has been reported in patients treated with disulfiram. And we certainly didn't want that in our study or in our patients, so we discontinued these participants from the study. So what we learned was that if anything, if anybody's ever doing another study, they should use much lower dosing than we did and for a shorter duration. We did find that 6 of the 9 people in our study, including those who dropped out but continued to be rated, 6 of those 9 participants were rated as responders, and they showed response in a variety of different self-report questionnaires. So it's interesting. Disulfiram is interesting. It's a powerful drug. It's a bit of a scary drug because it can have some very serious risks. So I'm not encouraging people to use it. And I'm concluding that only a large placebo-controlled study can assess efficacy, as expectation of benefit was high because people thought it was a miracle drug and may have biased outcome. Um, so that's all I can say about disulfiram, that it may be helpful for some patients, but we don't know. Okay, so with the generous help of the Stephen and Alexandra Cohen Foundation, we set up a national clinical trials network to help propel the investigation of different treatments for people with post-treatment Lyme disease, basically. And so we have all these terrific colleagues at UCSF in California, upstate New York, SUNY, upstate in Syracuse, Hackensack Meridian, New Jersey, Mount Sinai, New York, Columbia, New York, Johns Hopkins, Children's National Hospital in DC, and University of North Carolina at Chapel Hill. So we're fortunate to have such a nice team of investigators. And these are the mechanisms of disease that are being studied. So persistent infection. John Alcott at Hopkins is looking at 3 months of tetracycline versus placebo to see if that's helpful for these patients with persistent symptoms. And that could be because of persistent infection as the hypothesis. So it could also be that we know that tetracycline modulates inflammation as well. Pulse ceftriaxone is based on the observation in vitro that pulse ceftriaxone eradicates the Borrelia persisters as well as the active replicators. And so maybe if we give it to humans with persistent Lyme disease in a pulsatile fashion, maybe it would be helpful to them. As you know, dysautonomia may be a feature of post-treatment Lyme, along with inflammation and central nervous system network dysregulation. So we thought at Columbia that wouldn't it be interesting to see a vagus nerve stimulation using a transauricular, meaning by the ear device. So this little device here is a transauricular vagus nerve stimulator to see if that's helpful. I'll tell you a little bit more about this later. We decided to look at transcranial direct current brain stimulation, where you wear this strap around your head here. It has electrodes on it. It's delivering stimulation to your frontal lobes while you're doing cognitive remediation to try to enhance the retention of improvement from the cognitive remediation. Immune dysregulation, as you know, occurs with post-treatment Lyme, but it also apparently can occur just from the tick bites themselves. So Scott Cummins at University of North Carolina is really interested in this, and he's an immunologist. So he decided, and he says these symptoms that the patients are experiencing are a lot like symptoms he sees with his mast cell patients. So he's doing mast cell modulation therapy in a controlled fashion to see if it helps people after tick bite. David Petrino and Amy Prohl at Mount Sinai are really involved with long COVID. So they've been looking at microclots and platelet hyperactivation with long COVID, but because they had this all set up, they started to look at it with some of the long Lyme patients and finding that there are some indication of microclots in those patients. So that's not been published yet, but based on that, they designed this study using a proteolytic enzyme to see if it might help these patients either with long COVID or long Lyme or Epstein-Barr virus-related chronic fatigue. And finally, Sarah Mulkey, who's a neurologist at Children's National Hospital in DC, is asking the question in an observational study, can we see whether women who develop Lyme disease during pregnancy have healthy outcomes in terms of their children or unhealthy neurologic outcomes? So she's doing a very careful study of that. It's very hard to find these patients. So if you know anybody who gets pregnant uh, and uh, and has Lyme disease during pregnancy or maybe even somewhat before pregnancy, please have them contact Dr. Mulkey. Okay, let's see. So let me tell you a little bit about the vagus nerve stimulation. Why study the vagus nerve? Well, it's really interesting. It's the longest cranial nerve in the body. It innervates lots of organs, the lungs, the stomach, the pancreas, the liver, the esophagus, the heart. It also innervates the brain. So it stimulates a lot of different networks in the brain. So here's um, and another thing it does, in addition to all these various areas in which it's connected, it also modulates inflammation. So it's been very well demonstrated to modulate inflammation and decrease tumor necrosis factor in patients with rheumatoid arthritis, for example. So vagus nerve stimulation is fascinating because it avoids the risk of infection that might be associated with systemic immunosuppressive therapy. So some people who are on immunosuppressive therapies may be able to come off and be treated with an implantable vagus nerve or an external vagus nerve stimulator. And these are really high quality studies showing the inflammatory network. There's also been some good mouse studies of vagus nerve stimulation suggesting benefit not only for the peripheral inflammatory effects, but also for central anti-inflammatory effects. So there's a mouse model of sickness behaviors that was published in 2022 showing that vagus nerve stimulation helps decrease those sickness behaviors. It helps prevent hippocampal microglial activation. So you saw that previously in one of the Lyme human slides, the microglial activation. So could vagus nerve stimulation reduce some of that microglial activation? And then here is another mouse study showing decreased inflammatory cytokines in the joints of those patients in the blood, and then also decreased inflammation in the joints of the mice with Lyme arthritis as a result of vagus nerve stimulation. So fascinating work. And as you may know, vagus nerve stimulation is FDA approved for epilepsy, refractory depression, migraines, post-stroke upper limb rehabilitation, and most recently in 2025 for rheumatoid arthritis. So these are all the cluster of symptoms that we tend to see: headaches, depression, neurologic problems, arthritic problems. So could it be that vagus nerve stimulation given externally by the ear might be helpful? So that's what we're investigating. Okay, and then there's that study looking at forehead stimulation of the frontal lobes to see if that might help. And the recent study came out on long COVID just a couple of months ago, showing that that in fact has been helpful for long COVID brain fog. So maybe it'll be helpful for long Lyme brain fog. And there's the pregnancy study described in greater detail. So just to sum up, we know that mood, cognitive problems, suicidal thoughts, sensory arousal are common. You should screen for depression and suicidal thoughts. Please do so. People may, if they have neuropathic or arthritic symptoms, that ups the ante, that maybe this might be a Lyme-related problem. You can develop neuropsychiatric Lyme symptoms early in infection or late infection, and many improve over time, which is the good news. Some do have residual significant cognitive neuropsychiatric problems, which is quite sad, but if you catch it and treat it early, people tend to do better. We don't know. There's a whole bunch of areas of investigation we don't know. The long-term effects of other tick-borne and associated infections. We don't know what the long-term effect is of having multiple tick-borne infections. So for treatment, number one, assess the adequacy of the prior antimicrobial treatment. Focus on the most burdensome symptoms. So if someone's coming in with severe depression and they have a history of Lyme disease, treat their severe depression. If someone has severe sleep problems, treat their severe sleep problems first. And then if that doesn't get the person better, then focus on what might be persistent problems from Lyme disease. Obviously, give them lots of validation because these patients have been invalidated over and over again. Do not avoid standard mental health treatments. And I'm hoping that you're hopeful that new treatment approaches give us a nice possibilities for the future. And I know that there are lots of other treatments that could have been studied, and we're only presenting some of the ones that were studied in our center. So we're going to try to continue our clinical trials network. We're trying to expand the network if we can. We'd also like to have multi-sites doing the same studies so the studies get completed faster. So it's the great thing about having a network. You can do that. So this is my team. And I want to thank the FDC Foundation of Canada that helped support our Disulfiram study, and the Stephen and Alexandra Cohen Foundation, and the Global Lyme Alliances that has been a huge supporter of us over the years. So thanks so much for your attention.